So, today we are going to take on one of the most challenging, fascinating, and interesting trials in recent memory, the ORBITA trial. It is fascinating because the implications of the trial are so far-ranging. The implications should really make us think not only about heart disease, which is what the trial is about, but should make us think about how we do science, and more importantly, it should make us think very hard about what kind of information we accept as evidence. This trial really shows the flaws in what I have begun to call the narrative fallacy. Dr. Rohan on Midlife Crisis calls something similar to this the mechanistic fallacy. Whatever you call it, it is the susceptibility of human beings to believe a good story. Andrew Huberman is a classic example of this. Peter Attia, Rhonda Patrick, the big names in sort of longevity science, if there is such a thing, are all guilty to a huge degree of engaging with this fallacy. And it is not intentional. This fallacy is something that is deeply, deeply human. We pay attention to stories because stories are meaningful. In the sense of John Vervaeke and his meaning crisis, which we are doing a podcast series on, stories are a part of the way that we understand our lives. We understand where we are in our lives. We understand what has happened in our lives, what might happen in our lives. We participate in the creation of our story because we perceive our lives as having direction, and that direction gives us a sense of meaning, purpose, fulfillment. Without story, without the ability to perceive our lives as stories, we would be at great risk of losing that sense of meaning. Unfortunately, however, because human beings are hardwired to find stories meaningful, we are susceptible to others who use storytelling as a way of making points. Any marketing class, any marketing book will tell you that you need to tell a story because human beings do not respond emotionally to data. We respond emotionally to stories. And unfortunately, our buying decisions, our purchasing decisions, and often our medical decisions are driven by emotion. And stories are a quick way to engage with our emotions. Now, these stories are everywhere. In recent memory, the story that was told by Theranos and Elizabeth Holmes hooked in a bunch of very smart people, very intelligent, savvy investors, scientists, agreed to be on the board, agreed to work with Theranos because of the power of the story that they were telling, despite the obvious scientific flaws. In more recent memory, we have been taken in by stories about things that treat COVID. It works in a lab. Here's a story about my grandpa. He took ivermectin and he didn't die. But when we do science, we do a randomized placebo-controlled trial for a reason. And that reason is to overcome the human tendency to believe stories. Just because it kills COVID in a petri dish or in a test tube does not mean that it will work in a human being. Just because some drug works in a mouse does not mean that it will work in a human being. Just because some gene is associated with some condition does not mean that the gene causes the condition. These are all examples of the narrative fallacy. I've discussed some of the flaws with that genetic reasoning in a different video, which I will link. I have discussed also in another video which I can link, the flaws of treating sepsis with vitamin C. And I went over in that video how compelling the story would be, how biomechanically plausible it was, how much evidence there was to support the idea that vitamin C would be an important treatment of sepsis. Only when a placebo-controlled trial was finally done did we realize that it was an ineffective treatment. And so it is with ORBITA. ORBITA reveals that our story of what causes stable angina is flawed. What is stable angina? Well, in order to understand ORBITA, in order to understand the impact of ORBITA, I have to take you through a rather long but thorough explanation of our understanding of heart disease. I'm going to tell you the story of heart disease and stable angina as we understood it prior to ORBITA. And you will see how compelling the story is, how obvious the conclusions are, and how startling it is when ORBITA showed us that those were wrong. So, this is the shape of your heart. Your heart pumps blood. In order to do so, it is a muscle. It squeezes just like any muscle, like your bicep. In order to do so, it has to receive blood. It has to receive nutrients and give up carbon dioxide, take up oxygen, just like any other muscle in your body. These are the arteries that supply your heart with blood. There are three big ones. Any of them can be subject to developing a blockage. Now, a blockage looks like this, where cholesterol plaque has built up on the walls of the artery and has made it narrow. It has narrowed the flow of blood through that artery. As a result, the muscle that is supplied by that artery does not receive enough oxygen, especially if it is working hard. So if that muscle is pumping harder, then the demand for oxygen, the need for oxygen is higher, and when the artery is narrowed, it is unable to meet that demand. If the artery is open, but a cholesterol plaque suddenly ruptures in and a sudden clot is formed, that is known as an acute MI or a heart attack. And because there is a sudden stop in the blood flow, the muscle is injured quite dramatically. On the other hand, if the buildup of the cholesterol plaque is slow, gradual over time, and results in a gradual narrowing of the size of the artery, then these symptoms may not occur suddenly. At some point, when the person is exercising, the narrowed artery will no longer be able to supply enough blood, and the person will develop some symptoms. So, let's talk about the clear case. What happens when someone has an acute heart attack? Suddenly, that blood flow is cut off. The muscle that is depending on that blood receives none. If you've ever had a blood pressure cuff put on too tight, that painful feeling of your arm being deprived of fresh blood is exactly what happens in your heart. That results in symptoms that are typically described as crushing chest pain, the sensation of something very heavy, a heavy weight on your chest, shortness of breath, profuse cold sweating, often nausea, some lightheadedness is possible. The pain will often radiate up into the left side of the jaw or down the left arm. And that is the typical illness script of an acute heart attack. Many people do not have all of those symptoms. In fact, we know that women typically do not have as many of those symptoms typically as men do. Diabetics often do not have as many of those symptoms as non-diabetics. But that is considered the typical experience of cardiac pain. The part of the muscle that is not receiving blood ultimately is not able to squeeze anymore. It will not be able to produce a contraction, and thus the ability of the heart to pump is impaired. In addition to the pain and the symptoms I mentioned, The ability of the heart to conduct electrical activity is also impaired because you need blood supply to provide the electrolytes, and you need the muscle to actually remain intact in order for that to happen. There are typical changes that can happen with a sudden blockage. We call that ST elevation because an EKG usually looks like this. This is the ST segment, and in some acute heart attacks, the ST segment changes and starts to look like this. The ST elevation is highlighted here in yellow, and for those medical nerds among us, the blue sections are what's called reciprocal changes. These are the typical EKG findings of an ST elevation MI. Now, it is also possible to get a blockage of the heart, not quite so severe or so sudden, where the electrical activity does not have the typical pattern. Instead, we merely are able to detect in blood work the leakage of enzymes from those damaged cardiac muscle cells. Without the EKG changes, that is called a non-ST elevation MI. We're not super clever in the naming things in medicine. But in patients who have either an ST elevation MI or a non-ST elevation MI, we absolutely know that fixing the blockage fixes the problem. There is an acute blockage of the heart. When we go in and remove that blockage, the patient markedly improves. ST elevation has a much tighter time window. For a non-ST elevation MI, you usually have a slightly larger window, but within 24 hours you want to remove that blockage. This is how a stent works. The patient's blockage has a wire passed through the cholesterol plaque, through the narrowed artery, and a tight mesh of metal with flexible hinges is slid over that wire and then inflated with a balloon. The balloon is deflated, the wire and balloon are removed, and what is left is a wire mesh keeping that artery open so that blood can flow freely. In the case of an acute MI, what we know is that such a procedure reduces death and reduces future heart attacks, is life-saving without any question. Multiple studies have confirmed this. Now, there is another group of patients, as I mentioned before, who do not have a sudden blockage of their heart, but the blockage slowly evolves. It gets gradually worse over time. The symptoms that they may experience are exactly the same as with a heart attack. When they walk for a couple of blocks, they may experience shortness of breath, chest pain, which is crushing in nature, cold, clammy sweat, nausea, all of the above, radiating down the arm. For that reason, we obviously suspected that the pain was due to the same issue, a decrease in blood flow that could not meet the demand of the heart. The very first stent that was ever put in was in 1977, and it was in a patient who had one of these gradual onset blockages, what we call stable angina. Angina is the name we give to that typical set of symptoms. That's the type of pain. And stable means that it wasn't sudden, it didn't pop up out of nowhere with no activity, but consistently over time, the patient experienced the symptom with activity and it got better with rest. We know that the symptoms are the same with this non-acute or stable angina. And so we go in with a stent and we open the artery, and lo and behold, the patient's pain is relieved. That first stent patient was pain-free for more than 20 years after that stent was placed. We also do have some medications. The medications open the artery a little wider. They relax the muscles that keep that artery tight. Or they slow your heart rate down so that the demand for oxygen is less. There is one, ranolazine, that works by a different mechanism, changes the metabolism in the muscle cells of the heart and reduces nerve activity. But most of them work by either slowing the heart down or opening the arteries a little wider. And in placebo-controlled tests, those medications are effective in relieving the symptoms of angina, of stable angina. How effective? How do we know that they are effective? Well, one of the ways we do this is we have a standard exercise protocol. We put the patient on a treadmill and we start them walking, and then we go faster and we go faster and we go faster and faster and faster. And at some point on that standard protocol, the patient is not able to continue because they have so much pain, or they have shortness of breath, or they become weak. For whatever reason, the patient says, "Nope, I got to stop." And the amount of time that they are able to go on that protocol is what we call the exercise time. So we know that the medications are effective because the patient is able to go longer on the protocol. On average, the anti-anginal medications, that's what they're called, help patients go on average of 48 to 55 seconds longer on the protocol. Now, that's actually quite a long time because it's quite an intense protocol. So being able to go for 48 to 55 seconds longer actually translates to quite a significant improvement in day-to-day activity. However, these medications have not been shown to reduce the risk of future heart attacks or death. And that kind of makes sense, right? Because they just open the artery a little wider, or they slow the heart rate down, but they don't reduce the risk of having a heart attack. Now, I mentioned that the first stent was put into a stable angina patient in 1977. In 1992, the ACME trial was done and compared doing a stent in a stable angina patient with medical treatment in a stable angina patient. And from here on out, I'm only going to be talking about stable angina patients. That is, where the blockage is slowly creeping up and causing symptoms only with activity and relieved by rest. I am not talking about anyone that is having an acute heart attack, because that's settled and resolved. We know that there's benefit reduction in mortality. Clear. ACME showed that unlike the angina medications, where the improvement was 48 to 55 seconds, putting a stent into that blocked artery increased the walking time by 96 seconds on average. They also showed that the pain relief was more complete. The people that had the stent, almost 64% of them were pain-free compared to 47% of those who got medication. So in comparing a stent to medication, and medication had been compared to placebo, so we knew the medication worked because it had already been compared to placebo. So then we compared stenting with medication, and the stenting worked better. In 2012, there was the FAME-2 trial, and that attempted to determine whether putting a stent in would reduce heart attacks, would reduce mortality from these slowly creeping up blockages. So if a patient is having symptoms and they have a blockage that has been slowly creeping up, is blocking more than 70% of the artery, if we relieve that blockage, do they have fewer heart attacks? And this is a critical point, because FAME-2 showed a benefit, a reduction in heart attacks in the group that got the stent. It showed the benefit early in the trial, and the trial was stopped early. Because of the degree of benefit, it was considered unethical to continue. There are major trials in medicine, Jupiter, Sparkle, major trials that are considered landmark trials that were stopped early. Now, FAME-2 ultimately was disproven by ischemia in 2020. They actually finished the trial. But we already had a hint that that would be the case, because the Courage trial had been done in 2007, and there was no benefit to putting a stent in. But FAME-2 came along, and because the early data showed a benefit and the story was so good, of course, if you go in and you open the artery, then of course you're preventing a heart attack, right? Of course. And so they stopped it early. And we waited 8 years to actually do a complete trial on that topic, only to find out that stopping it early was a mistake, because it was just a statistical anomaly that the early data looked good, and perhaps the rest of the trial would have shown that there was no benefit, which is what ischemia showed in 2020. So then, briefly, I'll mention the PROMISE trial in 2015 showed no benefit in outcomes for CT scanning. All these coronary calcium scores that you see all the cardiologists liking to order. Yeah, we've known for almost 10 years now that there's no benefit there. Because the coronary calcium score really only shows you stable plaques for the most part. I'll talk about Cleerly here later on. They're trying to show unstable plaques. But again, we're going to express our doubts about what's going on there. Anyway, this is the environment in which ORBITA was done. In 2017, the ORBITA trial. So the ORBITA trial calculated that they would need 200 patients to compare putting a stent in for stable angina versus a sham control. We'll get to that in a second. But they needed 200 patients to detect a 30-second difference in exercise time. So they were aiming to be able to tell, and they calculated that the study should have enough power, enough people in the study to tell whether putting a stent in or not putting a stent in would benefit patients by at least 30-second improvement in their walk time. They were very conservative because previous comparisons had showed a 96-second improvement. They took those 200 patients. They made sure that each of them had at least a 70% blockage. That was documented on an angiogram. So there was no guessing. All of them had a blockage, all of them had symptoms, and all of them had limitations on their exercise test. They gave all 200 patients medical therapy of at least 2 anti-anginal medications. And they did that for 6 weeks. After the 6 weeks, the 200 patients were randomly selected into one of 2 groups. One group, they went in with a wire, they found the blockage, and they put a stent in. They opened that artery back up. The patients were sedated, they were wearing headphones playing music, and all procedures were required to last at least 15 minutes. Because the second group, they went in with a wire, they looked at this blockage, and they did nothing. They did not put a stent in. After the procedure, or sham procedure, they retested the patient's exercise time. And lo and behold, there was no statistical difference in the improvement between the fake procedure and the real procedure. Both groups improved, because that is the power of placebo. That is why we do placebo-controlled trials. They improved by, statistically, the same amount. There was no statistical difference between the two. Remember, the trial was powered to detect a difference of 30 seconds. So if there is a difference, it is less than a 30-second difference. They also did questionnaires on quality of life, and there was no change in quality of life, or no difference in quality of life between the group that got the stent and the group that didn't. So now, 3 years later, 2020, ischemia was published, showing no improvement in mortality either. And so at this point, we have a challenge, because our story is that when the blockage narrows, it increases the risk of the person having a future heart attack, and it causes them to have a limitation in their ability to go about their daily lives. It causes a loss of quality of life. It causes shortness of breath, and it causes chest pain that prevents them from being active. The story also tells us that if you go in and open up that blockage, the pain will be relieved, the exercise time will improve, and the person should be at lower risk of having future heart attacks or dying. And now, none of those things are true. In fact, there is no reduction in death or future heart attacks. There is no improvement beyond placebo in quality of life or exercise time. And in fact, all the previous studies since 1977 that seemed to show a benefit in stenting were in fact all revealed to merely be placebo effect, and were powered by the fact that the placebo effect of procedures is known to be stronger than the placebo effect of medication. One way to think about this is that because we had a story, we accepted comparisons between stent and medication as if it was evidence, as if it were data. But it is not data. It was merely the difference between the placebo effect of a procedure and the placebo effect of a medication. But the story, the compellingness of the story, prevented us from investigating further for nearly 40 years. For 40 years, we were putting stents in, amassing more and more evidence that this works, because each and every cardiologist has hundreds, if not thousands, of patients who had stable angina, who came in, got a stent, and said, "Thanks, doc, it really made me feel better. I feel so much better. I'm able to walk now. My shortness of breath is gone. Thank you so much." For 40 years. Thousands and thousands of patients. And we struggle a lot, both in medicine and as people, as humans, with the notion of the placebo effect. Surely that pain, that chest pain, that shortness of breath that I was experiencing could not have been improved by placebo. Surely not. Not me. I couldn't be fooled that way, could I? Of course you could. We all could. We are humans, and we are susceptible to storytelling because that is how we find meaning in life. There is no greater purpose. There is no more relevant thing than a story. And yet, in these circumstances, false stories can lead us astray. I talked with Dr. David Moore in a podcast episode on genetics about how we have this story that genetics are a blueprint or a code, and that code is like computer code, and we're just running off of that code. Or it's like a blueprint, and we're just houses that are built on that blueprint. That genes are transcribed into mRNA, and mRNA is then translated into proteins, and these proteins go off and do all the things that bodies do. That is a completely flawed and false story. That is not at all how genetics works. But that story compels us to misinterpret information. When we read a study that says that this gene is associated with a 4 times higher risk of heart disease, we go, "Oh no, do I have that gene? It causes heart disease." No, it doesn't. It's associated with heart disease in our current conditions, in our current cultural context, in our current population. The causation arrow is only implied because you think you know the story of genetics. You think that genes cause things. And we don't stop to consider that things can cause genes to be turned on and off because we have the story stuck in our head. Here the story was that the narrowing of the artery reduced blood flow, prevented the muscle from contracting, which is true so far. We know that actually even in ORBITA there was an improvement in the muscle contraction on stress echo. But that impaired muscle contraction causes symptoms, causes pain, and limits exercise tolerance, and decreases quality of life. Those conclusions were false. I emphasize the difference there because one of the important things we need to understand is the difference between truly objective measurements and subjective measurements. Exercise time, like it or not, is a subjective measurement because it is a measure of patient tolerance. By contrast, an objective measurement is fractional flow reserve, blood counts. These are things that are repeatable and are not as subject to patient mood. Now, we do know that the placebo effect affects objective measurements. That's even a greater confounder. But certainly for subjective measurements, the placebo effect can be quite profound. No one likes this. Doctors in the field objected very strongly to ORBITA. Interventional cardiologists wrote into the journal en masse objecting, saying this can't be. I have so much evidence, but what they had was stories. They had thousands and thousands of patient stories, individuals who had been helped by this procedure. And the doctors were as taken in as the patients. It was very difficult for them to accept that all of those stories were placebo. We don't like the placebo. We don't like the idea that our minds can influence our biology. Now, I'm going to do a whole episode on placebo. This trial will feature prominently as well in that. But for now, I want to focus on this notion of story. Because doctors are as susceptible to the compelling power of a good story as anyone else. Most recently, I did a video on the Nordic trial showing that invitation for screening colonoscopy was not effective in reducing deaths from colon cancer or deaths overall. And the GI doctors are, again, just like the interventional cardiologists were in 2017, they are up in arms because they have done thousands and thousands of these procedures, and they believed in their hearts that they were doing good. Certainly, there are some financial incentives there in both cases, but I really don't think those are the driving factor. I think the driving factor is the belief that they are doing good, and the sense when evidence reveals that a story was false, the sense we have is the sense of having been taken in. The sense of having been fooled, maybe been fooled by our own mind, by our own weakness, by our own desire to believe. It's as if we paid good money for snake oil. And we have a hard time admitting that the snake oil is snake oil when it's revealed. It's deeply painful to us to have been taken in by a false story, to discover that we were living in an illusion, living in a delusion. And when that illusion is revealed, we may have become attached to the story. I find this process particularly challenging in today's day and age, when people like Andrew Huberman, Rhonda Patrick, are so good at telling stories, compelling stories, about how this receptor and this dopamine, and then they bind, and then this, and then it affects your brain chemistry in this way, and there's a dopamine reserve, and then you shouldn't drink caffeine until 30 minutes after you've woken up. It's a great story. It's a great story. But it is not data. Studies in mice, I'm going to do a whole episode on this too, but studies in mice are useless. If you see a study in a mouse, just throw it away or give it to a vet who treats mice. If the study is not a double-blind, placebo-controlled randomized trial in humans, it is not evidence. It's a story. And we should construct our stories from those trials, and when a new trial comes out, we should adjust the story to fit the data, not twist the data to fit the story. We need to be very careful about which stories we are telling. This applies to things like diets, whether it's keto or vegan, plant-based, Mediterranean, XYZ. If there is not a placebo-controlled randomized trial, and there's not, because it's almost impossible to do, then we have to admit that whatever we are doing is based on a story. Now, we have to choose to believe certain stories, but we should know that we're believing a story, not taking on evidence. This is not a data-driven process. We may adjust which story we believe as evidence comes out. I was keto for almost 2 years because I believed in the story. But then I was convinced by other studies that made me rethink that. And in rethinking that process, I let go of that story in favor of another story. None of it is evidence because we don't have that evidence. We cannot do an effective placebo-controlled randomized trial in a large enough population for a long enough time to be able to tell what diet is best. And yet we have to make decisions. And so, based on the best data I can find, I have constructed my own story. But I'm well aware that what I am doing is telling myself a story. And when new information comes out, I update that story as best as I'm able. I think that the definitive statements made by some of our most popular health influencers, especially on longevity, you got Brian Johnson spending $2 million trying to biologically be 18, even though multiple biologic tests, here's another link, multiple tests show that biological age doesn't mean anything. We don't have a test for biological age. We have nonsense and astrology, tea leaf reading in the blood, right? I'll drip your blood onto this thing, and then if I look at it under Saturn's light, then I can tell you what your biological age is, right? It doesn't correlate to anything. But nonetheless, it is a compelling story. And so that brings us to some of our latest treatments, like testosterone. I get a lot of questions about treatments for low testosterone from my patients. And the problem there is exactly the same. Is if you are asking me, will testosterone help me gain muscle? Yes, it will. Absolutely. Will testosterone make me feel better? Will testosterone increase my energy level, my attention? Those are subjective measures. I do not have an objective way of measuring that, and there have been no placebo-controlled trials on testosterone's effect on fatigue, mood, etc. We have lots of stories. Great stories. But they're just stories. Now, if one of my patients chooses to believe in those stories, I can't fault them. I have certain stories that I tell myself about diet or exercise, but I cannot say that we have evidence. Now, the same is true of many things. The symptom of brain fog, long COVID, chronic pain, Lyme disease, black mold. We have all these illnesses where the symptoms are subjective and we do not have data. We do not have evidence. And in all of those same cases, each and every one of those patients has a personal struggle with the notion that any part of their symptom could be psychoneurological. And that is the challenge of the placebo-controlled trial, is if I take that patient and I inject them with testosterone and they feel so much better, and it turns out that I was injecting them with saline, they would feel duped. They would feel misled. They would feel angry. As well they should, because I would have lied and violated informed consent. But the real issue there is they would feel taken in. And I think that we struggle with the notion that placebo is effective. Really push on our buttons to say, hey, there is no good way of preventing heart attacks by putting stents in, even though it sounds so logical. So that brings me to Cleerly. a new AI-driven CT scanner for coronary artery disease. Once again, they are unwilling to do studies on outcomes. The studies that they have done compare their CT scan to the angiogram, and they say it compares favorably with angiogram results. But if we know anything from these trials, it is that in patients who are not having an acute heart attack, the angiogram results are not relevant. All the patients in ORBITA started with at least a 70% blockage. That was a requirement to get into the trial. Ischemia showed that even with patients that had high degrees of blockage, there was no improvement in mortality. So even if this Cleerly CT scan does show very accurately the degree of blockage, until they do an outcome-driven trial, it doesn't mean anything. Because we know that for stable plaques, there's no benefit to stenting. So, conclusions. First conclusion is that ORBITA showed that we need to be doing more sham-controlled trials of procedures. We do placebo-controlled trials of medications all the time. What we do not do is sham-controlled trials of procedures. And then procedures like stents for stable coronary disease are allowed to go on for 40 years because of a good story. Second, the placebo effect is real. We may not like it, but it is something we have to face. Subjective measures are more susceptible to the placebo effect than objective measures. That's why depression trials always have a tremendous placebo effect. Third, we need to be incredibly careful to distinguish between a good story and good evidence. A good story should be based on data, on information. It shouldn't be spun out of the ether. I should be able to say that I have this belief about nutrition, this belief about exercise, this belief about this, based on these things. But I also need to be able to say that that's not evidence, that's a story. We do not know the optimum way of growing muscle. There are endless debates in bodybuilder forums on the best way to grow muscle because we don't know. We know some things, we have some data, but we do not have placebo-controlled randomized trials on the best way. We know things that work and we know things that don't work because they have done controlled trials, not placebo-controlled, because that's very difficult to do with weightlifting. Similarly, when you hear someone go on a long story that sounds so scientific about this data and this study and that study, you need to ask yourself, were these placebo-controlled randomized trials in humans? And if they weren't, take a little pinch of salt before you listen to the conclusion. Because very, very often, and there are thousands of examples in medical history, Zygris, ORBITA now most recently, hydroxychloroquine, I could go on and on. Very often in medicine, a good biologic story turns out to just be wrong. And the quality of a story, the entertainingness of a story, is not a good marker for its truth value. And lastly, as new companies come out with new testing methods, new blood tests, DNA methylation, AI-driven cancer detection, whatever it is, we need these companies to do responsible trials, not to take advantage of our human tendency to believe good stories. Just because a particular technology correlates well with angiogram, that is taking advantage of the naivete of consumers, not knowing that angiogram does not correlate with mortality, does not correlate with symptoms. These companies are taking advantage of the naivete of consumers and the storytelling relevancy of both consumers and physicians. And we need them to do better. We need true outcome-driven evidence of benefit. Evidence that they are measuring what they say they're measuring, that it is an important thing to measure, that making modifications, whether that's taking a drug or behavior modification, actually changes the measurement, and that when the measurement changes, the outcome changes in accordance with the measurement. It is a tough thing to get a reliable, meaningful test for any disease. And these companies are taking the easy way out, like Cleerly in particular, but many companies are taking the easy way out and presenting studies, presenting data that tells a good story instead of presenting evidence. All right. Thank you guys very much. Love to hear any comments you have.